Now, there are loads of sources of stem cells, and that's a great shopping list of what basically we know or familiar with at the moment. The only thing I didn't put on that list was cancer stem cells. Tumours and cancers and so on do arise from stem cells that have gone wrong. I've not put them on because it just sort of confuses the issue. But all of the rest are naturally, well, they're not all naturally occurring. All the rest are stem cells of various shapes and sizes. And there's all sorts in there. I'll be mentioning them as we go along. But the ones to focus on initially are the ones with the asterisks next to them, that little star. So bone marrow, hematopoietic stem cell is HSC, that's blood-forming stem cell. MSC is mesenchymal stem cell, that's a tissue-forming stem cell. So the bone marrow produces both of these. The peripheral blood is simply mobilized bone marrow stem cells. It just makes life easier for the collection of stem cells. And cord blood, hematopoietic stem cells, blood-forming stem cells are there as well. Now, all of those have asterisks on. And the reason I've done that is that we want to understand initially where we are with the use of stem cells. And those stem cell types with the asterisks are the only ones in current clinical practice in the world. So the first thing we gather from this massive shopping list is that we have lots and lots of stem cells out there, but very few, in fact, basically bone marrow and cord blood, that are being used clinically just now. This is not a problem, but it does reflect that we need to do a lot more work in so-called translation medicine. Translation means taking a laboratory idea or concept to the clinic, and we have been quite slow on that in stem cell technology. There's lots and lots of ideas out there, but no one's really getting their head down and taking stuff to the clinic. And that's where my interest is. I'm a clinical scientist, but my interest is translational medicine, so that we can bring these things to the clinic and start to help people with them instead of just talking about them in journals and so on and so forth. So that's something to think about. But the main message here is that we have very few stem cells that are in current clinical use. All the rest are either in clinical trial or they're being proposed as some sort of vague treatment with no real proof of safety or efficacy, and that's a problem. Okay, I mentioned human embryonic stem cells, and I'll put them on largely because there was a massive hype about these, and it's really quite annoying in the area of stem cell technology that the media love to talk about embryonic stem cells. And when they were first discovered, they were sort of, people were throwing their arms up in glee and saying, oh yes, we're now going to cure everything with these. The hard reality is that they're actually very difficult to create. And they have some safety concerns. They may even have the potential to cause tumours in recipients, so that's a big problem. They're technically difficult to create, and there's been a load of hype. There is one notable application or clinical trial underway, which is macular degeneration, which is a disease of the eye. But other than that, there's very little going on. And the reason for that is that to obtain embryonic stem cells, you have to destroy a human embryo. So you take a human embryo, you dissect it up, you take out the bit that you want for the stem cells, and the rest is discarded. So that process in itself is highly controversial. People will say it's a life for a life sort of approach, and it's very, very problematical. So for that reason, they've not really developed, and and personally, I've never worked on them. The reason for my not working on them is that I can see very clearly that we can do everything that we want to do without using human embryonic stem cells. So don't want to hang around too much on that. Now, bone marrow. Remember, bone marrow is the figurehead, if you like, of regenerative medicine. It's been around for many, many years, since 1956, first transplanted. And the basic applications are to treat leukemia, blood disorders, and following high-dose chemotherapy for things like solid tumours. So it's been transplanted, it's tried and tested, it's safe and effective, so that's fantastic. There's been another recent development of so-called haploidentical, horrible scientific term, but it means a near match. And what we do here is we can take a donor who is a near family member of a patient, who may be a sort of semi-match for that patient, and by using clever technology to remove some of the immune cells, and also by using modified and improved chemotherapy, we can actually do a transplant when the tissue match is quite poor. Traditionally, a bone marrow transplant needed a 100% match. And if it didn't, then that was not possible to use. It would cause such major problems in the recipient that he couldn't do it. But now with haploidentical, you can take near family members and they can be used as a transplant donor for bone marrow. So that's absolutely brilliant. And haploidentical is now the first line treatment for most blood disorders, leukemias and so on, where they can't use the patient's own stem cells. So that's a really important development. Other things in bone marrow is the use of bone marrow to treat multiple sclerosis. Now, multiple sclerosis is an autoimmune disease, so it occurs because the immune system is starting to attack the nerves, basically. And the concept here is that we use bone marrow to effectively reboot the immune system in MS patients. It's a very invasive treatment for something like MS, but it has shown great benefit to some patients, and so we have great potential here for a new level of understanding and a new application in bone marrow work. I say it can be difficult to find a donor. The reason that's there is simply because in the old days it used to have to be 100% match. Another exciting area that's coming up in the use of bone marrow stem cells is the use of another type of stem cell called mesenchymal stem cell, MSC, which are tissue-forming stem cells. And these are found in bone marrow. Now, there aren't very many found in bone marrow, and so the technology that's been developed by people like Opus Biological is to take bone marrow and to expand or increase the number of MSCs, mesenchymal stem cells, in that bone marrow. Now, the point of this is to use these cells in the treatment of musculoskeletal disease. So things like osteoarthritis and so on, and sports damage and people with dodgy joints. These stem cells can be used to treat these patients very effectively. They reduce inflammation, and of course, they also contribute to the repair of the damage. So MSCs can form things like tendons and connective tissue. And so this is a very, very interesting and important development. Now, there are various groups around the world doing expanded MSC bone marrow for musculoskeletal work. But traditionally, they used to do sort of manual expansion of the cells, very labor intensive, very difficult to control, and not very cost effective, really. So what we have now, and that's what that little picture is on the left, are things called bioreactors. That one's from a company called Miltenyi's, the Prodigy bioreactor. And what this does is it takes the bone marrow MSC stem cells and it expands them inside a bioreactor. Now, this is much more easier to control. It produces a much more or a much better product, and from a regulatory point of view, it's easier as well. So things like bioreactor expansion of bone marrow stem cells for the treatment of musculoskeletal disorders are really becoming extremely important. And I believe that this will be the next thing that actually comes into routine clinical practice around the world, because we're at that stage now where we're showing fantastic results and everything seems to be going well. So that's a little bit on bone marrow. Peripheral blood, I'll mention this very briefly, just because it is effectively bone marrow stem cells that have been mobilized into the peripheral blood. This is done by a range of drugs, including things called CXCR4 antagonists. Don't need to worry too much about that. But all of these things basically allow the stem cell to come out of the bone marrow into the peripheral blood. And there's a bit of science there. The CD34 is a marker of the stem cell in the bone marrow. Once it's in the blood, it's possible to use that machine on the left called a apheresis machine to collect the stem cells from the blood. And then the stem cells can be used for the very same applications. This is often used on patients to collect their own stem cells, and then they're treated and they get their own stem cells back. That's called an autograft. Or it can be used for a donation. People can donate their cells by this route now, and they can be used for anyone in need. It's in current clinical use, it's first line, it's gold standard, and we will improve it over time, but we're in a very safe place now in terms of this technology where we really understand it quite well, and it can be applied to all sorts of different things. Okay, the next one that's of interest, and these are some of my personal interests. Obviously, we all think our own research is the best, and our own research is wonderful. And but the thing is, we need to keep an open mind. It's very easy when you get focused on something and you think it's fantastic to sort of close your mind to options, and that's a bad thing. Across the whole of science and the whole of medicine, we always need to keep an open mind, and we need to be able to, if the time comes, say, okay, my technology wasn't the best, this is the best, and off we go. So that's the way in which I try to work. It's not the way that many people do work. So adipose stem cells, fat. This is fat, usually from the abdomen, which contains stem cells. It contains mesenchymal stem cells, which are tissue-forming stem cells. These cells can make connective tissue, muscle, nerve, and so on. Adipose stem cells have been worked on quite considerably over the recent years. And in fact, there's a very recent publication there from my colleagues and I talking about adipose stem cells. And the advantage here, of course, is that we all carry excess fat around, whether we like it or not. And if we need something like a mesenchymal stem cell treatment, and say perhaps bone marrow isn't available, or adipose tissue may provide better effects, we don't know at the moment, then adipose tissue could be used as a source for these MSC cells. They form bone, they form connective tissue, so they can be very useful in musculoskeletal disease. They're also very useful in anti-inflammatory. And in fact, colleagues at Abu Dhabi Stem Cell Center in the UAE used nebulized MSCs to decrease the inflammation in the lungs in COVID-19 patients. So this shows that the scope of and the potential of these things is absolutely astonishing, that we can take these cells and do these things with them. These types of cells, in fact, all MSCs, are also possible to donate from person to person without any worry about rejection. So that's another useful thing about these cells. So once again, keeping an open mind, these cells or this approach is very interesting. The paper I mentioned, we actually used a mechanical processing system for the fat. So the fat's collected and it's mechanically digested, and then it's given back to the patient. There is also the option of using enzymes or chemicals to digest the fat. The drawback with that is that this increases the regulatory requirements. And by the way, regulation is absolutely critical in stem cell technology. We need good regulators in every country. And the reason I say this is because it will protect patients. My main interest is translation medicine, but my ultimate interest are the patients. And if patients are suffering from botched stem cell treatments, it gives a terrible reputation to the whole thing. It brings us down, and regulation can cure that. We have excellent regulation in the UK, and many other countries do, but some countries have little or no regulation. And of course, this opens up the possibility for people to offer untested, untreated, untested, unproven treatments, which causes big problems. So in terms of the future of stem cell technology, regulation is probably the most important thing, next to understanding all of the techniques and so on. Cord blood transfusion, I've added this just because it is of great interest to me personally. And I've got some fantastic colleagues in India who actually work a lot on this. Professor Narenjan Bhattacharya is an example of the world leader, actually, in cord blood transfusion. And the concept here is that we take cord blood, which is the blood left in the placenta when a baby's born, and I've mentioned it in terms of stem cell transplantation, but it also is an excellent product for transfusion. So instead of using donated adult blood, we should be and could be using donated cord blood for transfusion to supplement adult transfusion, and also in some cases even to replace donated adult transfusions. As I said, most of this work has been pioneered by colleagues in India, and you can see there that there's been some extensive use of this technology in various diseases, really in any situation where transfusion's needed. That's basically it, really. If we've got a situation where transfusion is needed, then cord blood is great. And it has the benefits that it carries more oxygen than donated adult blood. And that's really important, especially in trauma patients where perhaps the oxygen saturation is low. Fantastic for that. It's also rich in chemicals which can repair tissue. And of course, it contains stem cells, which may or may not have some sort of action in the regenerative process. So really, really very interesting. I've recently published a paper there, you can see with my colleagues in Nigeria, talking about the use of cord blood. I mean, in sub-Saharan Africa, blood transfusion is very, very difficult to carry out from donated adult blood. And if we could introduce something like cord blood transfusion, where we collect blood from birth, then that could be a big thing for everyone really, but especially for some of the developing countries. Okay, I mentioned mesenchymal stem cells. I thought I'd just let you know a little bit more about them. They're not hematopoietic, so they're not blood forming, they're tissue forming. And I mentioned things like using them to treat COVID-19. That is because they can regulate the immune system. When the immune system is getting a bit carried away in things like osteoarthritis or multiple sclerosis or anything along those lines, COVID-19, then MSCs in theory could be used to help. They carry all of those markers. I'm not going to drone through those because it's all a bit boring, but we use those markers basically to show us that we're talking about the same cell. This has been a problem in the past, that people have been talking about cells and everyone describes it in a different way. So these markers are a way in which we're trying to standardize the way in which we talk about cells of all types, but especially stem cells, so that when one scientist is talking to another, then we know that we're talking about the same cell. Umbilical cord tissue and placenta and amniotic fluid. Now, these are so-called products of conception or products of birth, and they do have a role, and they could certainly be used in the future in stem cell technology. Umbilical cord tissue, the umbilical cord itself, is currently being collected and stored. This can be done privately for the mesenchymal stem cells that it contains, and that's potentially useful in the future. The placenta is quite a large organ. It's about the size of a dinner plate. It's up to about 1.5 inches thick, something like that. So it's quite a big organ. It's difficult to process, but I believe that part of the future of regenerative medicine lies in stem cells derived from placenta. So we need much more work on this to really understand what we've got in there, first of all, and then secondly, to develop potential treatments using placental stem cells. Really important. Amniotic fluid collected during caesarean section is also very important, contains stem cells and also contains some important chemicals which can help in things like severe burns and such like. So we need to keep an open mind once again on this. It's very much in the starting phase as this kind of technology, but we need to keep on going. You may be surprised to hear that there are stem cells inside teeth. We've all got teeth. I've got a fewer than most, but there are stem cells in there, and you can see that diagram on the left, that there are various types ranging from the stem cells that exist before the tooth actually erupts through the gum, all the way to the cells that can be collected when a deciduous tooth, a baby tooth, is lost, and then to the adult tooth. And these are mesenchymal stem cells, so they're potentially clinically useful. But the problem with this is that there are very few cells in there. So if we ever came to using this kind of technology clinically, it's almost certain that we would have to do some sort of bioreactor work. And that's not a problem. There are some brilliant bioreactors around there, like the Terumo Quantum and Miltenyi Prodigy and a few others. So there are plenty of bioreactors, but the cells as they stand, certainly using current technology, we simply don't have enough cells to be clinically effective. So there's, once again, a massive amount of work. People do collect and store baby teeth when they're lost in some cases. This is always on a private basis. This is not a public service at the moment, so people have to pay to do this. If they choose to pay to do it, that's fine by me. But what I'd like to see is more focus on the public storage. Bone marrow, there are bone marrow registries all around the world containing stem cells available for transplant. The same goes for cord blood stem cells. There's registries for that, and that's fantastic. I was involved in the development of one of the first registries in Canada, actually, when I worked in Toronto, the Victoria Angel Registry of Hope, which is one of the biggest cord blood stem cell registries available. But at present, there are no such registries for things like adipose tissue or dental pulp or placenta or those kind of things. So if you do want to store these, then it does have to be done with a private supplier. And it can be quite expensive, and potentially it could be useless. So you need to think carefully. And in fact, in my book, I give some advice on private storage of stem cell.